Starting with the physiology of water balance. Body water, it constitutes for around 60% of the body weight. So if you look to this slide, for somebody who is around 70 kg weight, 2/3 of this water, is inside the intracellular compartment. So the total water is around 42 liters, and 28 of this, that is 2/3, is in the intracellular compartment, and 14 liters in the extracellular compartment. And if you subdivide the extracellular compartment, you will find that around 3 out of 4 present in the interstitial fluid. That's contribute to around 10.5 liters, and only 3.5 liters in the vascular space. For the control of the body, the water can move from the intracellular to the extracellular, compartment freely. But we have another control, and that's by the brain as well as by the kidney. So first of all, we have a thirst mechanism. The thirst mechanism is very important. So if somebody feeling thirst, so it will encourage the person to drink good amount of water. The same thing can happen with a little change of the serum osmolality. And this change in the serum osmolality, either secondary to medication, or secondary to nausea, or secondary to vomiting, or raise of the plasma sodium. This will lead to secretion of what we call it the antidiuretic hormone, and the kidney will try to preserve water. So this slide again to show you the renal handling of water. So almost all the water, it will pass through the GFR. Part of it will be absorbed in the proximal tubule, but the main place for the water control, it is in the collecting duct under the effect of antidiuretic hormone. So for water homeostasis, to occur, so we need intact thirst mechanism, and this is very important. That's why, people who develop hypernatremia, usually the people who cannot access water, or they have impaired thirst mechanism, like intubated patient. You have to get normal antidiuretic hormone or vasopressin secretion. That's why patient who is having deficiency of antidiuretic hormone or resistance, they will have diabetes insipidus. And again, you will have to get intact GFR. That means good kidney function. So patient with renal failure, they will accumulate fluid because they will not be able to excrete the excess fluid. So when we look for the balance of the input and output of the fluid inside our body, you can see that from the beverage around 1.2 liter, and from food around 1 liter, and from the metabolism of water, and this by oxidation around 300. So all these together around 2.5 liter of water. In the same time, so we have an output, and this usually occur from the urine by around 1.5 liter, insensible loss from the skin and lung by around 900 milliliter, and by the feces around 100. And this is all of it, it will contribute to the loss either by the kidney or to what we call it the insensible loss. And I think that is very important, especially from the lung and from the skin. So if somebody having fever, it's very important to adjust for this insensible loss, as it will increase by 100 to 150 ml per day for every 1 degree of temperature increase above 37. Again, the GI is very important source for the loss of water as well as to electrolyte. So if we look to this table, it's very important. I'm comparing here the saliva, the gastric juice, the bile, pancreatic juice, small intestine, as well as diarrhea, and also to the loss by the skin through the sweat. Sodium, you can see by saliva is around 40, and from the stomach is around 70 to 120. So that's why it's very important in surgical patient who is connected to nasogastric tube aspiration. By the bile, the same thing for patient, who is having, drainage, in the bile for whatever biliary surgery, they can lose around 140 millimole per liter of sodium. And from diarrhea is around 120 millimole. And this is very important when we come later on how to replace the fluid in the setting of diarrhea. For potassium, most of the potassium available in the saliva and from the gastric juice and from the intestine around 10 millimole per liter. The same thing for chloride. You can see that the chloride content available in the gastric juice, in the bile, as well as in the small intestine and in the sweat. So how the fluid kept inside our capillary? From this diagram, there are two important forces that control the balance of water inside our vessels. The first one, we call it the capillary hydrostatic pressure, and the second thing is the oncotic capillary pressure, and this is usually controlled by the serum albumin. So if we move from arteriole to capillary to venule, so you can see that in the arteriole side, there is excess of the hydrostatic pressure. So the hydrostatic pressure here is around 35 and the oncotic pressure is around 25. So we have around 10 millimeter mercury difference in favor of the movement of water outside the capillary. So when we move into the capillary net, there is no net movement of water because the hydrostatic pressure almost the same as the oncotic pressure. As we move toward the venule, so you can see that there is reduction of the hydrostatic pressure and the oncotic pressure is constant, so that's why the water will be kept in the venule in this side. So if there is any disturbance in this mechanism, as there is increase in the hydrostatic pressure or there is reduction of the oncotic pressure, so the water will move from outside our capillary toward the subcutaneous tissue and the patient may present with edema.